in the beautiful Dubai morning today. My name is Junaid Razak. I'm professor of emergency medicine at Johns Hopkins University in the US. And it's my great pleasure to moderate this session this morning. We have two excellent speakers. Before I introduce the speakers, I want to make sure that those of you who have nice music on your phone to please turn the volume down if you can. And the plan today is we'll have a talk and then perhaps a couple of questions if we have time, and the second talk, and after that we'll have an opportunity to actually have a panel discussion of sorts. So it's my honor to introduce you to the first speaker, Professor Colin Graham. He's Professor of Emergency Medicine at the Chinese University of Hong Kong. He is Honorary Consultant in Emergency Medicine at the Prince of Wales Hospital, Hong Kong, and Editor-in-Chief of European Journal of Emergency Medicine. Dr. Graham qualified in Glasgow in 1994 and undertook specialist training in emergency medicine in Scotland. He moved to Hong Kong in 2004 and was appointed professor in what used to be called Accident and Emergency Medicine Academic Unit at the Chinese University of Hong Kong in 2007. He practiced clinical emergency medicine at the Prince of Wales Hospital. He has broad research interest within emergency medicine and has published widely. He's going to talk about something very important, the long-term trauma outcomes, strategies to cope with financial burden on society. Welcome, Professor Graham.
Thank you, Junaid. Good morning, everyone. Have you had your coffee? Good. I just want to make sure your eyes are still open. So, thank you very much, Junaid, and my thanks to Nadim and to Salah Fares and the whole committee for inviting me to speak today. It's always a pleasure to come to the UAE, to this conference, which is getting better and better and better every year. So, thank you. So, one of my big interests in research over many years now has been long-term outcomes. And when we were talking with the organizers about the title of this, we eventually settled on strategies to cope with the financial burden on society. And you'll see as I go through this discussion that there's a slight problem with this approach, only in as much as there is almost no data on the financial burden in society after trauma. So we'll come to that in a little while, but I'm going to take a slightly more generic view and think about burdens in a more global sense, rather than just financial burdens. So I work in Hong Kong. You'll have gathered from the accent that Hong Kong was not my place of origin. I'm slightly taller than the average Hong Kong person, and maybe slightly heavier as well, just a little. I suspect my leg weighs more than most people in Hong Kong, but I've been working there for a while. But my other hat, and part of the reason I'm completely jet-lagged out of my skull at the moment, is that I edit the journal in Europe, and I've been over in Europe for the last few days. So if I collapse at any point in the next 30 minutes, you'll know why. I do get some money from the journal. There's nothing I'm going to say today, I think, that will have any conflict of interest with that. Now, this has been a topic that's always been of interest to me because we traditionally have always thought of trauma and outcomes as being a simple matter of death and survival. And many years ago, I set out to do what most people would call a PhD. In Scotland, we call it an MD, to look at what are the other aspects of outcomes. But this took a very personal angle for me when my younger brother managed to fall out of a window in London back in 2005 when I was in the middle of doing my research on this. And he managed to be one of those 0.5% of people who survived to get to hospital intact with a ruptured thoracic aorta. And it gave me a very, very different perspective, seeing trauma care from the point of view of the relative as well as from the point of view of the clinician or the researcher. So I've really found this a particularly interesting thing, and I'll come back to my brother's case at some point towards the end, really just to emphasize how if you get good trauma care, your outcomes can really be so much better than we expect in this day and age, if your system can work. I would argue that in the modern world, there's an awful lot more to outcomes than survival or death. We really have to think about how we survive. And this morning already, we've been talking about trauma, we've been talking about stroke care. And of course, the difference between those two in terms of outcomes is that trauma still tends to be predominantly a disease of the young, relatively speaking, whereas stroke tends to be a disease of the older patient. And I would argue that the importance, particularly of returning to work and having an active contribution to society, is incredibly important when it comes to injuries. And that really is because when we talk about financial burdens, but also burdens in a more general sense in terms of community, we're talking about a drain on resources. If you have a devastating head injury, you get fairly substandard care, or indeed if your primary injury is just so bad that your recovery is very limited, you will be a net drain on your health care and family resources for the rest of your days. But getting a good outcome will reverse all of that. But more importantly, you'll become a net contributor as well. So instead of just draining your community's resources, you may actually even contribute to them again. And that obviously is a financial issue, but it's much, much, much more than that. Head injuries are the ones we talk about a lot when it comes to this, because obviously that has a very direct linear relationship in many cases with functional outcome. But for other injuries, particularly spinal cord injuries, the difference can be even more significant. And there is, of course, potential for patients with spinal cord injuries in some settings to go back to being full, active, contributing members of society, if the community is prepared to support them. But in many parts of the world, to this day, a spinal cord injury is a complete death sentence, because the community and domestic circumstances and income levels do not allow for those patients to have a long-term outlook. The group, though, that's really been underestimated for years are the lower limb injuries, though. Lower limb trauma has been shown now for close to 20 years to be one of the biggest predictors of not going back to work. And most of this work has come from the States, as I'll show you. And they are particularly important because of their prevalence. And we do underestimate the impact that these have on patients. I've got a case to show you, just to get you excited. If you've had your lunch or your breakfast, you may not want to look at the photos in the next couple of pictures, the next couple of slides. This is a young man who I saw close to 10 years ago in Hong Kong. He was driving a lorry. He had a seatbelt on. He was driving along the highway, and it was about 8:30 in the morning. And we don't know if he fell asleep or if he just got distracted or quite what happened, but he was doing about 100 kilometers an hour. That's the speed limit on most of our highways. And he ran slap bang into the back of a stationary truck. I think this is a scenario that many of you will see on a fairly frequent basis. He was trapped in his vehicle for about 20 minutes. I can assure you that his airway and breathing were absolutely fine, because I could hear him screaming when I came into the emergency department. He was screaming like a banshee because he was in so much pain. He was hemodynamically okay. By the time I got there, the staff had given him 20 milligrams of IV morphine, which was really just a starter. And by the time we got to about 40, we were starting to bottle out a bit. We thought, 40 is quite a lot. And at that point, I dug out the ketamine. And ketamine really is a marvelous drug when it comes to these things. a tiny dose of ketamine, and he was very happy indeed. Unfortunately, his legs were not happy, as you can probably see here. Now the challenge here for those of you who can see this is to work out which foot is attached to which leg. There's a few people at the back just realizing what it looks like now. So let me go back one. So you can see he's got a nasty open knee here, and the leg comes down here, and this leg kind of comes up here, and then there's 2 feet, one of which seems to be pointing backwards, one of which is pointing to the side, and I'm not entirely sure which one was connected to which. And honestly, on the day that was the case, we were saying to ourselves, which leg is which? We're not entirely sure here which is happening. So another shot taken from a slightly different angle, and you can see there's remnants of something here. Again, we weren't too sure, and we could see this trainer and this leg here, and we couldn't all work it out. So I then did what we always do, and I cut the shoe off the foot, and that's what we were left with, was a horribly mangled, crushed right foot, which, as you could see, was, sorry if I can get the buttons to work, was pointing in the wrong direction from his leg. Those of you who are more astute will see that he also has a little kink in his leg up here, and he also had a fracture of his mid-shaft tibia and fibula as well. He was kind enough to bring some parts of the van with him as well. You can see there's paint and bits of steering wheel and pedals and things in here. And needless to say, the contamination was fairly overwhelming here. So he had a mangled right foot, and he had a fracture of his mid-shaft tibia and fibula. But he also had his patella fracture on the left, but more importantly, he had the kind of classic dashboard injury of an acetabular fracture, and importantly, he had a sciatic nerve palsy on the left as well. So here we had someone with a completely smashed to smithereens right leg and a potentially non-functional left leg because of his sciatic nerve palsy. And there wasn't an awful lot of bleeding, to be fair. There was just this very important issue that if we didn't sort out his hip and his sciatic nerve very soon, he'd be left with half a leg on one side and an insensate, functionless leg on the other. So he went up to the operating theatre directly and had a primary amputation of his leg just above the fracture site. He got his left acetabulum fixed primarily, and the hip was reduced. And then a couple of days later, he got his patella fixed after it was washed out on the first day. He was in intensive care for about 5 days. His inpatient length of stay was close to 4 months. But he eventually went back to work 3.5 years later. 3.5 years of a 36-year-old not contributing to his community and being a drain on his community in some ways. And with that life-altering set of injuries, he clearly wasn't in a position to go back to driving a long-distance lorry, nor did he feel like it, because he had psychological issues as well, obviously, after the event, something that's always completely underestimated. So that case and many others that we've seen over the years made me think again, well, what are we doing right here and what are we doing wrong? Is amputation a good thing for these patients, or should we try and reconstruct them? We've had other cases in the last few years where, despite looking at limbs that look fairly similar, our surgeons have decided to go ahead and do a 10-hour heroic reconstruction, which, then needs multiple operations over the next few weeks, and after 2 or 3 months ends up with an amputation in the end. And there's relatively good data now to suggest that primary amputation is probably just as good as an attempt at reconstruction. And some of that decision-making obviously has to take part with the patient themselves. Boss and McKenzie, Ellen McKenzie from Baltimore, who's done a massive amount of work on this, showed back in 2002 that only 50% of patients with injuries like this are back at work within 2 years. 50% is pretty poor for something that ultimately is not life-threatening. It's life-changing, but not life-threatening in most cases. So why are we so bad at this? Part of it is because we have many inconsistencies in data collection. We don't know what's important for trauma outcomes. And if you review the literature on this, every single person, every single research team has a different viewpoint on what is or isn't important. People have looked at all sorts of things, from the psychology through to the physical, through to the functional. And there's very little consistency between any of these. I've always got to remind myself in particular, having come from the UK and now working in Hong Kong, that we are very lucky to at least have mortality data. There are many, many countries out there that still don't even know that basic level of outcome data. And clearly the emphasis has got to be on improving mortality and survival. I'm sure you'll have heard that yesterday from Lee Wallace as well. It's about improving mortality before we even think about morbidity. So we've done some work on this both in Scotland and more recently in Hong Kong, and I want to show you some of the stuff we've done in Hong Kong. We've tried to do this prospectively because we feel this is the only way you're going to collect the data. Using routine retrospective data to work out outcomes is well nigh impossible. You cannot do it from routine clinical records. Even mortality is hard to work out sometimes from routine clinical data, and morbidity is almost impossible. Things like the functional independence measure, for example, you should be certified to do that prior to doing it. And I would argue that that's something that's easy to do in a rich, well-endowed financially country, but in most of where we work, that's not going to be possible. So our prospective study has been running now for 7 years, and we're just about to start another one, which I'll tell you about shortly, but we looked at 3 of the 5 trauma centres in Hong Kong. Hong Kong has about 7.5 million people, and we don't see a lot of trauma. We don't see a lot of penetrating trauma. We see a fair number of road crashes, pedestrian knockdowns, and high falls. If you want to commit suicide in Hong Kong, you jump out of a building, typically the 8th or the 9th floor. They don't give as much in the way of trauma survivors as you can imagine, but when they do, it tends to be lower limbs and pelvises. But we see a lot of road trauma. So we included patients for about 9 months, who were 18 to 70 and with a modest or severe injury severity score of more than 9. And obviously we wanted to know about mortality, but we also looked at the Glasgow Outcomes Scale, which is really a head injury scale. It's similar to the Rankin Scale for stroke, but with extra components to take it up to 8, and I'll show you that shortly. And we used the physical and mental component summaries of the SF-12. Now the short form 36 is a generic health status tool, which is used widely. And the big advantage of SF-36 is it allows you to compare across disease paradigms. So it's been used a lot in rheumatology, it's been used a bit in cardiology, it's been used a fair bit in stroke disease. So to some degree, it allows you to look across different diseases and compare outcomes, which is important if we're going to justify funding for things like trauma services, as opposed to everything else. And everything, of course, is important, but for me, I think this is very important. And we also wanted to look at return to work status, because ultimately, this is where the finance comes in. If you can get back to work and you can pay your taxes, then you're contributing positively to society. If you're not working, then you're draining. Now, the other big advantage of the SF-36 is for each place, or for many places, there is a norm that's been developed, and that norm has been calculated through community surveys. So in the original US version of the SF-36, the norm for the physical component summary was 50, and the norm for the mental component summary was also 50. It's a normalized score, so it's done towards a normal distribution. Now, compared to that standardized US figure, you can develop a norm in each different locality. And for us, the PCS was 52.8 and the MCS was 47.2, which probably means, to put it simply, that most people in Hong Kong are relatively physically fit, but maybe not so good mentally, to put it in summary. And that's not surprising, given that they're all half the size of me, they eat vegetables, they don't smoke, but they live in a very stressful place. So that kind of intrinsically makes sense to me. I don't expect you to be able to see this slide. This is the slide showing some of our outcomes with our 400 patients that we recruited at baseline. But I really just show you this to detail how difficult it can be to track these patients. We have a computerized tracking system in Hong Kong that lets us look at outcomes in terms of mortality, but even then, with an inability to contact people, say at 2 years, you then have to start checking the data to see who's alive and who's dead. Clearly, telephoning dead people isn't going to give you much data, and it just upsets relatives. So you do have to be quite sensitive when you're doing this. But we had a reasonable follow-up rate over our time, and we managed to track at least 50% of them for most of it. Interesting differences really in age. Again, as we've alluded to in a few of the discussions this morning, you see that obviously the young people are more commonly involved in road traffic crashes. Young men are the predominant people who get injured, and the severely injured tend to be more elderly, but the numbers are relatively small. And we see as well, though, there is a problem in that the major trauma patients who get a trauma call, 50% of the younger patients get a trauma call, but only 22% of the more elderly patients get a trauma call. And likewise, less of them are admitted to intensive care and less of them have surgery. So there's definitely an elderly bias here that we see. And I suspect that happens across the world. And of course, in terms of getting people back to work, I suppose that's not too surprising, but we also need to think of more generic features of life as well. Now, this is the interesting one, I think. So to take you through this is the Glasgow Outcome Score extended. And essentially, from left to right, this is dead, which is clearly not so good, vegetative, severely disabled, modestly disabled, and then good recovery. So clearly, you want to see the peak at the right-hand side rather than at the left, because the left means you're dead. And we go here from 1 month to 6 months to 1 year, 2, 3, 4, and 5-year outcomes. So again, the amount of work to collect all this data is astronomical. You're tracking these patients. And patients also get very fatigued by this. They don't like being phoned every month or every year or every 6 months to be asked how they're getting on. And frequently our research team has had, well, you phoned me last month. No, we phoned you a year ago. But no, it was only last month. No, it was a year ago. And people just get sick of it. And it's really quite hard to get this. But the essence of it is, as you can see, that at 1 month, most people were fairly severely disabled, with a few deaths. Over time, not surprisingly, the number of dead does increase, but part of that is natural attrition. We have an elderly population. But you can see that you're still getting changes right up to year 3 and maybe even year 4, where people are going from lower good recovery into upper good recovery. And you get a shift towards the right in terms of outcomes. Now, what that implies to me is that you get most of your changes happening up to 1 year, but you still get some changes as late as 4 or 5 years down the line, which gives us some useful information on when we should be considering intervening with these patients. And this slightly more simple one is just the trajectory of the physical component scale of the SF-36, and from 1 month to 6 months to 12 months. And you can see that the sharp incline really happens between 1 month and 6 months for the physical component score. But there's still a steady increase all the way up to 4 or 5 years. So we have an opportunity to intervene in terms of physical outcomes early, and yet that's what we don't do. We tend not to prioritise rehabilitation at the earliest stages, and it may be that we should. Now, bear in mind, this is across the board. This is not just lower limb injuries. But I suspect if we were to look at them specifically, we'd see something very similar. Interestingly, with mental component summary scores, we go from a relatively low level here at 1 month, not too surprising if you've been hit by a bus that you feel a bit down. But interestingly, it increases up to above the normal. And it stays above the normal. Now, if anyone can explain that to me, I'd really like to know, because I can't fathom that. Why do you mentally feel better 6 months after you get hit by the bus than you did before? And I think that in itself is worthy of some more investigation. Now, I'll pass over this one because this is just the predictors, but the most important thing here is that the outcomes are predicted really by your original physical component summary score. So if you're doing okay at the beginning, you'll do okay at the end. If you're not doing okay at the beginning, you won't. So again, it tells us that the intervention has to happen early, not late. So we took a subgroup of this and we looked at the return to work status. And again, we started with 400 odd, and we had about half of those individuals were working or seeking employment at that time when they were injured. In your setting, in your individual countries, you may find that that percentage is higher. We have an elderly population in Hong Kong. We have very small numbers of children and young people in Hong Kong, relatively speaking. But in your countries, you may find that significantly higher, which means you have all the more potential to intervene. Few deaths in the group, as we said, but we managed to follow these people up over time. And what we found was really interesting. If you look at the mortality, it's relatively low over 5 years, but the time it takes to return to the Hong Kong norm is highest in the extremity group, although that's not statistically significant. Time for MCS, again, there's no real difference, but the mean time to go back to work ran as high as 3.6 years in the extremity injury group. And remember, these are often thought of as patients who really aren't that bad because it's just a limb. And they're the ones who take close to 4 years to get back to work and are non-productive. Even the spines in the other body regions, although that's very small numbers, were less than the limbs, which may reflect the fact that spinal injuries, rehabilitation is very targeted to them, but not so much to the limb injuries. Another way of looking at this is to use Kaplan-Meier curves, survival curves, which are more commonly used in oncology, as you know. And the essence of this graph, this is looking at time to return to work. These are head and neck, thoracic and abdominal injuries up here, and the green line here is the lower limb injuries. Again, just showing what we've said already in a different way, that these patients take longer to go back to work in any way, shape, or form. And if we take MCS and PCS, so PCS is the physical component summary score, MCS is the mental component summary, again, we can see a divergence here with the physical aspects of recovery really trailing behind the other groups when we're talking about extremity injuries. And in the mental health component group, they're very parallel lines. So what we've done since then, basically we've extended this recently to look at these 3 trauma centres again, but with a much bigger cohort. We want to get 1,200 patients this time. And we've extended this down to look at patients with less severe trauma as well. Because again, you would expect that patients with less severe trauma would be more likely to get back to work sooner. So we might be able to get some more results in these people compared to the ones who are severely injured. And we're going to track these patients over a year, over 12 months, to see if we can get some data on where we could intervene to try and improve this. So I would argue that there's a lot of different burdens here that we can see in our own setting, and I have no reason to think that this wouldn't be seen in other settings as well. In North America, this has been studied to some degree, but again, the caveat is that there is huge variation in the terminology that we use. Obviously, there's massive amounts of direct medical costs, and we'll see that in a minute. In developing countries, that can be catastrophic for families. The secondary complications we get. Do you need an amputation after 6 months of expensive reconstructive surgery? Are we really doing the patient any favors, either financially or clinically? We've got ongoing care in the community for those patients who can't get back to a functional outcome. There's non-medical costs, there's indirect costs associated with mortality and morbidity. There's all those opportunity costs, there's all those costs where you could have been making money, but you couldn't because you were in a hospital bed or you were stuck at home. Some studies have adjusted, some studies have not, but measuring loss of productivity and disease burden is really very, very hard, and there's not a lot of good data on this generally. This is a study that was published in Injury Prevention some time ago that looked at the burden, if you like, the disability-adjusted life years by different kinds of injuries. And you can see here just there's huge variation between the different regions of the world. Huge variations over what we can see. And again, the data is relatively poor. If we look at injury costs in low and middle income countries, we're looking at direct and indirect costs of somewhere in the region of $4,000 US. A lot of money for poor families who can't afford it. This was a study from Vietnam looking at household costs and looking at how much of the household income an injury would cost an individual family. Road traffic injuries, 26%, falls 33%. Interestingly, assaults were relatively cheap, but probably that's because if you got assaulted and you died, it wasn't so expensive. But if you got a blunt injury, you would need lots of ongoing care as time went on. So what cost-effective interventions are out there? Well, clearly we know that road traffic safety and education can help. Improved pre-hospital trauma care does make a difference, but particularly in the context of systems. And that needs to be integrated with our hospital systems as well. It's the systems aspect that's been shown repeatedly to make a difference, both in North America and in Asia and in Europe and Australasia. That's where we need to see investment. We could target rehabilitation at specific groups. And you may ask yourself, why is an emergency doc even remotely interested in rehabilitation? Well, because at the end of the day, we want to see patients get back to function. There's no point in us doing everything that we do if it doesn't lead to patients getting their lives back. And that might mean we need community-based rehabilitation as well. And I would argue that at the moment we have just about no information on this. I have, in a place as advanced medically speaking as Hong Kong is, I have one rehabilitation specialist to look after 1.5 million people. And he spends his entire life looking after stroke care. He doesn't do head injuries. He certainly doesn't do anything on lower limb injuries. We have a different paradigm to address here that we're not currently doing. I was lucky enough last year to go along to this conference in London, which was put together by a group based at the Royal London Hospital by Karen Broy's group and Karen Hoffman. Karen Hoffman is an occupational therapist who is spearheading this drive, along with colleagues internationally, including from the US and from Germany and other countries. And we brought 31 people together to discuss the terminology that we should be using to address post-injury rehabilitation. Now, part of the problem, as I've mentioned a few times, is that the terminology is so different from country to country, from study to study. If we can at least get an Utstein-style reporting mechanism for this kind of work, then we can at least compare apples with apples, whereas at the moment, we just can't. And the website link is there if you're interested. This will result in a paper whenever it finally comes out, and we will have an international classification. Just as an aside, It's really interesting when you get 31 so-called experts in a room to talk about one topic. We had 2 days of blistering arguments. It was great fun, but it became very clear that we, even within this, specialized area, we don't actually speak the same language. And it just emphasizes really the importance of doing this at the outset. So the future, I think we need more data. You won't be surprised to hear me say that. I'm an academic. I want more data. I always want more data. But we need to do this in a standardized way. If it's not standardized, then we can't compare across systems. We can't learn from each other, and we can't implement solutions. We have to think about functional outcomes, because functional outcomes are what really gives patients their lives back. I told you at the beginning of the talk about my brother. He got his aorta reconstructed in London by an incredible team of vascular surgeons and radiologists and intensivists and emergency physicians and everyone at St. Mary's Hospital in London, and I will be forever in their grateful debt. And he went back to work, and I suspect he worked in finance in London. He made more money in a year than I'll make in my entire life. And I suspect his taxes will have paid back his 7 weeks in intensive care and his 2 thoracotomies 100 times over. I suspect he won't ever be able to pay back the 60 people who all donated a unit of blood to save his life, but that's maybe another topic. But the point is that by getting people back to a functional outcome, it pays not just for your care, but it pays for other people's care as well, and you can make a contribution to that community. We have virtually no randomized trials of early post-trauma rehabilitation, and we need to go down this path and address it in a scientific way, unlike what we've done at the moment. All of our data at the moment on costs is indirect. We have very few direct studies on cost in trauma. And again, that clearly varies enormously depending on the perspective and the setting in which the incident happens. But we need to look at it not just from the point of view of raw finance, but the career trajectory of the individuals involved. Clearly, if this happens at the start of a young person's career, it's going to have significantly more impact, potentially, than maybe someone towards the end of their career. But someone towards the end of their career may be making more decisions than the young person. So we just don't know the impact, and we should look at it. And we haven't put families into this at all. One of the really interesting things about the ICF process we went through last year was we had a patient relative representative on the group. She was the mother of a young man who'd had a significant traumatic brain injury on a bicycle, and she brought perspectives to our discussions that we would never have thought about. Never have thought about. And it was incredibly powerful to have that perspective in the room. Incredibly so. So we need to look at the family effects as well and look at the cost-benefit analyses so that we can get the best options for patients and the best options for their families. I'd like to finish off just by thanking my own team and the teams at Queen Elizabeth Hospital in Tuen Mun in Hong Kong and the funders who gave us the money for these 2 studies that we're doing at the moment. And I'll stop there and take any questions that you've got. Thank you very much.
For a wonderful presentation. We have time for maybe a couple of questions. I request people who have questions, please step forward, tell us your name and the question. Yes, please. Can we have a microphone here?
Hi, my name is Danish Sami. I'm the consultant in emergency medicine at Mafraq Hospital in Abu Dhabi. My question to you, Colin, is that we got the TARN data in UK and the trauma networking data. Now, I don't know about Hong Kong, but we are developing some kind of a data in Abu Dhabi as well at the moment, and we are in the initial phases. I'm just wondering, you said the retrospective collection of data in your study was difficult to get the outcomes that you wanted. That surprises me a little bit because TARN has been there for some time. It's been used properly.
You're absolutely right. And interestingly enough, we had Antoinette Edwards and Fiona Leckie from TARN were out with us just a few months ago having exactly this discussion. And you're quite right. The strength of TARN over the years, TARN is the Trauma Audit and Research Network in England and Wales. And the strength of Tarn has been that they've used hospital data coordinators, usually nursing staff, sometimes statistical staff, and audit staff, who that is their job. They prospectively collect this stuff. And you know, I, like you, have got so used to this happening as a concept, it seems to be routine. But when you work in our setting, we don't have that. And when we go back and look at our raw data in the clinical notes, it doesn't exist. And an example, I saw a 12-year-old just a few weeks ago who had a smashed head after a bicycle crash, was GCS 6, got a craniotomy twice on the night of admission, was in the ICU for a week. 7-page discharge letter from the ICU to the general ward, not a single mention of his conscious level on discharge. The one thing I wanted to know was, had this kid woken up or not? Not mentioned. 7 pages. I knew exactly what nutrition he was getting, and I knew what his urine output was to the nearest 0.1 of a mil, but they didn't write down what his coma scale was. So I think unless you know what you're looking for in terms of outcomes, and we clearly do, if the individuals who are documenting it don't work to that, you're not going to get the data that's there. But I think you're right. Organisations like Tarn, like STAG in the old days in Scotland, the prospective collection has been happening and we've not realised it. But it's necessary.
Thank you. Time for one more question. So while we are waiting, I'll ask you a question, Colin, if it's okay with you. So, you know, we have, for the treatment of stroke, emergency medicine clearly thinks about, we can do something to reduce disability because we know that we are not sure about the life saved by intervention. Now, what contribution would emergency or acute care improvement would make a difference in terms of outcomes for disability in limb injuries? Do you have the sense of that?
Yeah. I mean, I think that's a great question, and I mean, I think we. For limb injuries, it's probably not as obvious an answer, but I suspect that it's making those ultra-early decisions, particularly on surgical interventions, but also in pushing the paradigm or the system so that we get people into a rehab setting as quickly as we can. And I see that partly because as emergency people, we run the systems generally within our hospitals that deal with emergency care. Now, in some settings, it will be a trauma surgeon. In some settings, certainly in my hospital, there is no trauma surgeon, it's us. And having an impact on that pathway of care will come potentially from us. But I do agree. I think the reality is that the practical side of it, on you know, at the front door in the first hour, is still going to be about survival. But it may well be that if we don't get this data, I don't see anyone else that's looking for it. And that would then help us to push people into the right paradigm.
Great. Thank you so much, Colin. Again, appreciate your great presentation.